Hi, I'm Paul.
Hi, I'm Tim.
And I'm Pooja. As we know, physical therapy is one of the major components of managing Duchenne muscular dystrophy. For our project, we wanted to help people develop a better understanding of the physical and psychosocial coping interventions in different stages of a DMD patient's life, from when the patient is first diagnosed to when the patient unfortunately passes away.
We interviewed physical therapist Doug Levine and Jennifer Wallace Valdez from Cure Duchenne, a nonprofit that helps raise awareness and fund research on DMD.
My name is Jennifer Wallace Valdez. I'm a physical therapist. All of my patients have Duchenne and Becker muscular dystrophy. Over the years, I've probably had, I would like to say, between 40 and 50 patients with the diagnosis at all stages of it, from early diagnosis, infancy, all the way up until the time of their passing.
My name is Doug Levine. I live in Austin, Texas. I've been a physical therapist for 24 years, but over the last, I'd say 8 to 10 years, I've kind of specialized in Duchenne muscular dystrophy.
Both Dr. Levine and Dr. Wallace Valdez have a significant amount of experience working with DMD patients and lots of expertise to share on therapy. Let's get right into it.
Do you find yourself having to explain much to the child when they're that young, or do you usually leave that up to the parents? It must be hard to explain to such a young kid why it is so necessary for them to limit those activities you were talking about or stretch daily,
Sure.
because they have no idea what is to come, really.
Yeah, no, it's a fantastic question, because if there was something going on with you, I could explain that. You know, you're an adult. I could say, well, this is kind of uncomfortable, or this is a little time consuming, but this is the reason that we're doing it. And you can, okay, that makes sense. So as far as the disease progression, I mean, I leave all of that, how much to tell the child, what to tell the child, I leave that up to the parents, because that's their decision, but I try to help guide them if they want me to. And yeah, I mean, at the young age of 4 or 5, we're not really talking to the child. The parents aren't generally talking to the child about where you're going to be in 5 or 10 years, or, we're going to need a wheelchair way down the road. I guess it's like anything that's a little bit heavy. You talk to the child at their level and what they're ready for. So we try at that young age, we try to make things into a game or a distraction. So if we need to do stretching, the earlier we start, the more regular the activity becomes. So if we just do, hey, we're going to do a little stretching and let's watch a movie while we do it, or let's read a book while we do it, or if we're out on the playground, whenever I tell you, you got to come over and drink a little bit of water and just kind of sit next to me and take a rest break. So we're not really at that age, generally not explaining why we're doing all those things, or the reasons, or what we're trying to stave off. But we're just trying to make it a normal thing as best as possible.
What does physical therapy look like at that age when they are first diagnosed as such a young kid?
The physical therapy plan of care is not too cumbersome at that stage. It really is a lot of consultation, a lot of family education. And that's the most important thing I think we can do for families at that point, because it's a devastating diagnosis to receive about your young child. And to be basically told there's no cure, take them home and love them, is really hard for families to take. So I feel honored as a physical therapist to be one of the only solutions that they're given at that time. So we can take them on as a client and start educating them. This is what you should do. This is what you shouldn't do. So we try to deter them away from overusing their muscles, causing excessive damage to the muscle tissues. And so just educating the family on what types of activities to do for fun. They're children, they need to have fun, they need to play. And so we just try to help guide them better on better choices of activities.
So I know you had mentioned how at this age, between the ages of 8 and 12, a lot of these children lose like ambulation and aren't able to walk. And unfortunately, but how, as a physical therapist, do you help them adjust to that change, or like do you explain this, significant change from being able to jump around, run around with their friends and all, to unfortunately maybe being in a wheelchair?
Yeah, it's a very difficult time. The psychosocial aspects of it, I have to follow the family's lead. There's sometimes the boys, typically only affects boys, so that's why I say boys. Sometimes, I spend so much time with them, one-on-one, we really get a bond. And so they want to ask me questions. Why is this happening? What's going to happen next? I saw so-and-so at a conference and he can't walk anymore. Is that going to happen to me too? Those questions come up a lot. And I just try to always refer back to what the parents' wishes are. And sometimes it's difficult. And other times, the family's handling it really well. But I try to always have a positive outlook on things. well, look what we've already done. You've been able to walk, you've been stretching, you've been doing your program, and pointing out the things that they do enjoy doing instead of focusing on what they're losing. Talk about, what they do have and, the fun that they told me about they had last week at that birthday party. Things like that, so that they can be like, focus on the positive as much as possible.
So then transitioning to when they're a little bit older, say like prepubescent age, maybe between 8 to 12, does the physical therapy or the home therapy change much then?
By the time you get between 8 and 10 years old, you'll start seeing decline, sometimes rapid and sometimes slow progression. And maybe they can't jump anymore. Maybe stairs are getting more difficult. They can't keep up with their peers by that point. Most people with Duchenne will lose their ability to walk between 10 and 12 years old, although many are walking a little bit longer. So our physical therapy program, it's still to conserve energy, and it's still to help them prevent as much muscle damage as possible. So altering activities, making life easier for them to accomplish without damaging their muscles. We do a lot more soft tissue mobilization to the muscles, and to try to keep the scar tissue from forming and causing more issues. Their home program becomes more lengthy, so lots more stretching, lots of more long duration stretching, so positioning type devices. Aquatic therapy is a big thing on that age too. If walking has gotten so hard, but we still want them to move, because the opposite of overuse of muscles is disuse of muscles, and they're prone to losing muscle from both conditions. So if walking's getting harder, so they find themselves sitting on the couch or playing video games all day because they don't want to go outside and play, then we may have diffuse muscle atrophy issues as well. So if we can get them in a pool and say, hey, move around, get to it, have some fun, then they can, use their muscles in a safe environment.
When you are dealing with children that are like prepubescent, what is like the main focus of therapy in terms of what muscles are being targeted?
The muscles that we typically target are the heel cord, the gastroc and the soleus, the quadricep muscles, the hip flexor muscles, and then the wrist and finger flexors. And then we want to focus a little bit more on the upper extremities. There's really, with the kids, because there's so many standing difficulties, getting up from the floor, walking, that we tend to focus on the lower extremities a lot. And as we hit that mid or late ambulatory stage, we're starting to get more tightness in the upper extremities, in the pec muscles and the elbow flexors, the wrist and finger flexors. And if we don't watch that, or we don't address that, then all of a sudden when they hit the non-ambulatory stage and they need their upper extremities for everything, now there's significant tightness. So so I would say at that age, just to make sure that you're addressing the upper extremities.
And during this age, are there specific pieces of equipment that you use to support, if like the child, whether they're mid-ambulatory stage or like the late ambulatory stage?
The things that come to mind are night braces. So typically AFOs or night splints, as they're also called, those are typically used at night. And that should already be in place. I usually start that or make that recommendation at like 3 or 4 years old, before there's a lot of tightness. But definitely, if that's not on board, that's a piece of equipment, that those night braces, to help maintain range of motion as much as possible. As the kids are walking less and having more difficulties, then the three things that are probably the most important at that age, if not getting them for the child, at least starting the conversation and thinking about it, is a manual chair, possibly a power chair for longer distances, for energy conservation and decreased falling, like when the kids are in school going long distances, because at this point, at that 8 to 12 year range, they're having a hard time keeping up. And then also a stander, which is generally a passive piece of equipment where the child is placed in it in a standing position, and then there's pads and supports to keep them in that position. So they don't have to work to stand, but they can stand for 20 or 30, 40 minutes. There's usually a tray, so they can do an activity, but they're maintaining weight bearing, which is important for bone density, range of motion, circulation, digestion, respiratory, all of that stuff.
Do a wheelchair if they don't have one in place. So that actually is a hard topic, usually for the parents. But the boys are like, yeah, give me one of those power things. I'm like a transformer, or they call them the Iron Man chairs, whatever they want to call them. But now they're keeping up with their friends. They're not worried about falling. They're not getting hurt anymore. And so that stage, that 8 to 12 years old, is usually a stage where there's almost some relief that I'm going to get a wheelchair because I'm not keeping up. My buddies are over there. By the time I catch up to them, they've gone over there and I can't make it that far. So it changes the game a lot.
So how do kids try to maintain a normal lifestyle in terms of playing with their friends and doing daily activities, and how do you help the kids?
That's where the education part comes in, both for the family, the education and the guidance, both for the family and for the child, because I want kids to be kids and I want them to participate but we also can't ignore the disease, and we can't ignore things that might make it worse. So helping to kind of guide them, you know, if they were to sit on a couch and do absolutely nothing, they're probably going to minimize the damage to their muscles from overexertion and tearing and things like that. But there's a lot of physical and social and psychological implications to being removed from activities, and disuse atrophy and decreased cardiac output. So probably the word that I use the most to parents when helping to guide this is balance. It's got to be a balance. We have to let the kids be kids, and we have to let them participate and do stuff with their friends and go to birthday parties and do all the things that kids are doing, but also helping to guide that.
I think that starts at the very young ages. If you start to tackle it then, it really helps later on. So getting them comfortable with what they actually enjoy doing, that they're actually good at doing, so they can get their peers involved, instead of always being the one that, everybody else decided that they're going to go play football today, and so I'm left out. So really getting them comfortable with what I like to do, and finding the friends that are on the same page as them. The friends that like video games, the friends that like Legos, the friends that like to watch movies or comic books, that type of stuff. And then they get that bond very early. And those are the guys that I see do best. The ones that have close friendships, even if it's only one or two friends, they don't have to have a huge group of friends, but socially and emotionally, they do much better through the teen years and the high school years are so hard as it is for able-bodied person, to be in a power chair by the time you're in high school, it can be pretty rough, right? But if you have those close couple friends, it feels, I think, a lot easier to handle.
So in terms of the pandemic, how has that changed your practice and how you've been able to meet with the kids?
The pandemic hit my practice very hard. I went months without seeing any patients. So they're all immune compromised. They're all respiratory compromised, and we couldn't take any chances. So many just kind of hunkered down, and we didn't do any therapy. A couple did some virtual therapy with me just so that we could update their home programs, but really it was all on their parents. Here's, you need to notice what's wrong and report back to me. You need to, tell me how it's going and what's working and what's not working. But it really became all on the parents to try to figure out what's needed. So we also had a huge amount of my guys who lost function during the pandemic, because those who were still ambulating, even if they use a scooter for long distances at school, at least they were getting up out of their desk to go get a paper across the room or to walk out to recess and things like that. Well, now they're sitting at home behind a screen like the rest of us and not getting up and moving around. And, even if they do, they walk 20 feet to the kitchen and back. They're not getting the activity they used to. So I had many of my ambulatory patients have a significant decline during the pandemic, even with us trying to, institute new activities and activity schedules, things like that. It's just not as natural as what their daily schedule had been before.
Yeah, I was going to ask if you had noticed a lot of worsening disease at this time, because like you said, they can't really move much.
Yeah, and I had several too that missed their cardiac MRI or missed their spine X-ray, and so their scoliosis went unnoticed for a little while. They didn't get equipment delivered that was needed, that sort of thing. It hit all aspects of their lives. It's heartbreaking. Seeing my patients again, I don't even have them all back yet. So maybe about half of them have come back, and almost every appointment I walk out of it just upset, to see that how much we've let go, but we've done what we can.
Are there any specific exercises that you can have them do in their teenage years? Because I know most of them they're pretty much lost ambulation at this point. Is there anything specifically you have them do, maybe every day or during PT sessions?
Continuing stretching as they're moving more, sitting in a power chair more or a manual chair, continuing stretching, that's a lot of times not something they can do themselves, but that's an important part of it. When the kids have a power chair, we try to order the chair with as many power functions as possible. Tilt, recline, power seat, elevating, leg rest. So utilizing those throughout the day to change positions, to have different positions of their body, because they're not standing up and walking and moving around and changing position like we are. So having the chair functions be able to do that. And then finding there's more and more like power wheelchair sports, power wheelchair soccer, hockey, different things like that. So even if they're not able to walk around, if they're in a chair, having them still involved in sports, that's been shown to raise their heart rates as well, which is good for cardiac issues.
Well, it actually becomes even more cumbersome. So their physical therapy program, by the time they're not ambulating anymore, we have a lot more to treat. So the contractures get worse, and now it affects the whole body. Because before they were at least standing or moving and getting some motion through their joints, but to be seated all day long, to not be using your arms the way you used to, now we're worried about the arms. So, you know, when they're walking, they're opening doors, they're grabbing things, they're reaching, the arms are actually moving. But when you're in a power chair, it's like when you sit in an office chair and you're not typing or anything, you know, because there are joysticks on the on the armrest. So we start to see problems all over the body, the spine too. If the posture isn't supported in their chair, then the spine could also become drastically involved with significant scoliosis. So there's actually a lot that we need to keep an eye on and treat. Their home program gets more cumbersome. So hopefully it's not just still the parents doing the stretching program. Hopefully they have caregivers involved as well. The assisted technology becomes huge. So they're so reliant on other people, but what can they actually do for themselves if we get them the assisted technology? And especially now with smart home devices and all kinds of things, they could actually be more independent if we have the right technology.
How is the patient's morale and motivation affected during PT as, like, you know, their condition is worsening?
I feel like I've seen it all. I've seen the dynamics of families that have worked really well, and the guys go on to move out, live on their own, go to college, start their careers. And I've seen the guys that don't want to leave home, that are scared to be out in the world by themselves, and maybe miss opportunities to live their life, to have quality of life. I think the best scenarios I see is, again, starting young, but giving the boys the ownership of their body, of their independence. You know, letting them try to figure out, how am I going to accomplish this, instead of always being reliant on their parents. You know, I think if your child has a terminal diagnosis, you want them to be your baby forever. You take care of them. You want to take care of everything they could possibly ever need. But I think one of the most important things I've seen families do is give their son his own advocacy for himself. Like, here's how I ask for help. Here's how I identify what my needs are and find the right solutions. And those are the guys that I see, you know, find caregivers, move out of the house. You know, they manage their own 24-hour caregivers. They manage, you know, their transportation to get to college, to get home, to get to job interviews and all of that, because they've learned those skills at a young age, and they grew into the life skills.
This is a disease that makes your muscles weaker. This is something that makes you not able to keep up with your friends, but we also try to focus on what we do have and how can we participate, and the positives in life. So with Duchenne especially, well, with all diagnoses, but with Duchenne, there's a strong psychological component to it. It's thankfully something that's getting addressed a lot more these days. It used to just be really focusing on the physical and what are they able to do, what are they not able to do. There's a lot more webinars. We're addressing this in clinics. Even just one-on-one on the psychosocial state of the child and of the parents and of the siblings of the one that's affected. You know, how are you feeling? Are they showing signs of depression? Are they showing signs of anxiety as they're losing the ability to do stuff and they're in a more passive position in life? Is that increasing anxiety? There's also in a third of the cases, maybe more, of Duchenne, there are different psychological issues, increased OCD, kind of autism spectrum type behaviors. So those are being addressed a lot more too. And I think the pandemic has also compounded that. There's a lot of fear. A lot of these kids have fear in general, and now they have a bit more.
As we learned, life for a boy with DMD involves the use of various PT and mobility equipment, stretching exercises, and making compromises when participating in certain activities. The increasing physical restrictions faced by boys with DMD also takes a huge toll on them psychologically. Despite having to make lifestyle adjustments and deal with all these challenges, we should understand that many individuals with DMD are able to do much more than just cope. They can choose to adopt a positive outlook and lead a very fulfilling life.